Hello, everybody. You know what this is. Step 1 prep. Here we go. A 35-year-old man with pulmonary arterial hypertension is treated with an endothelin receptor antagonist. Which receptor is targeted? Okay, so we have to talk about PAH, pulmonary arterial hypertension. And it's a specific subset of pulmonary hypertension where the small pulmonary arterioles narrow due to endothelial dysfunction, smooth muscle proliferation, and fibrosis. And that increases resistance, and that raises the pulmonary arterial pressure, and that overloads the right ventricle, and that leads to cor pulmonale. All right, so you have that loud P2 sign, BMPR2 mutations, and endothelin 1 is overexpressed, and so you get vasoconstriction and proliferation. And that's why our answer is going to be C. And we're thinking specifically of basentan here. It blocks the endothelin 1 receptors, preventing vasoconstriction and vascular remodeling. That's the drug of choice. All right, so the two things to know is that PAH is caused by increased pulmonary vascular resistance, and endothelin 1, BMPR2, and right heart failure are associated. All right, so the mechanism here, the pathophysiology. First, we have an endothelial injury, and that decreases a lot of things. Nitric oxide is 1, prostacyclin is 2, and endothelin 1 would be increased. Then you get vasoconstriction and smooth muscle proliferation, the narrowing of the arterioles, and that increases the pressure. And then the pressure increase causes right ventricular hypertrophy, and then you get right-sided heart failure. And you have that loud P2 sign, dyspnea, fatigue, syncope. And you have normal wedge pressure because it excludes the left heart failure. And so basentan blocks endothelin A and B receptors. And you monitor the LFTs because hepatotoxicity is a known risk. Now, other things like the PDE5 inhibitors like sildenafil, those increase nitric oxide signaling. But here we're talking about basentan. So the answer is indeed going to be C. Muscarinic would be parasympathetic. Histamine would be allergies and asthma. Dopamine, renal neurologic pathways, and serotonin would be carcinoid syndrome migraines associations. So endothelin receptor antagonists are the primary treatment for pulmonary arterial hypertension. All right, our next question, we have a 45-year-old man presenting to the dermatology clinic with a progressively enlarging dark spot on his upper back that he first noticed about 2 months ago. He reports some itching but denies bleeding or pain. He has a history of frequent sunburns but no significant past medical history for medications. Physical exam shows a 1.5 centimeter irregularly shaped, asymmetric, darkly pigmented lesion. A biopsy is performed and histopathology demonstrates atypical melanocyte proliferation with pleomorphic pigmented dendritic cells. Which of the following is the diagnosis? A lot of nice answers here. So let's go through each one by one. But first, I want to talk about the signs. 1, we have progressive growth, asymmetry, and irregular border. We have UV exposure, frequent sunburns, and histology shows pleomorphic melanocytes, dendritic, and pigmented, and so that's a key melanoma feature. And so some trap answers are going to be seborrheic keratosis. That's a stuck-on, waxy appearance, and the histology shows horn cysts, not pleomorphic melanocytes. Dermatofibroma is a small, firm brown papule, and histology shows fibroblasts, not melanocytes. Kaposi's sarcoma is going to be HHV-associated vascular tumor, especially in HIV. Histo would show the spindle cells, not the melanocytes. Merkel cell carcinoma is a neuroendocrine tumor, and histology shows the small blue cells with a high mitotic rate, not the pigmentation or the dendritic. All right, so melanoma accounts for just 1% of the skin cancers, but it causes the vast majority of skin cancer deaths. And so you got to do something about it really early on. And you got to learn your ABCs, right? It's asymmetrical. The borders, right? Benign moles are symmetric, but melanomas are chaotic, and that's because the genetic mutations, which causes their irregular shape. The border irregularity as well happens because melanomas invade adjacent borders. So they have the scalloped or the notched borders. And there's also C, A, B, C, D, right? So C is color variation. And I should actually just write this down. So A is asymmetry. I mean, that's why I got my notepad here, right? A, B, C is the color, right? So the color variation, there's black, brown, blue, red, white. That's just the uneven melanin production or hemorrhaging. And then D is the diameter. And if it's greater than 6 millimeters, larger lesions have more time to mutate and grow unchecked, whereas the benign stuff is usually pretty small. And then the evolution, is it changing? So the change in the size, the shape, the color, the symptoms, that's a key sign of the malignancy. So melanoma is a malignancy of the melanocytes and is driven by BRAF V600E mutation and induced P53 mutation. It grows rapidly at first, and then it grows vertically, and there's a risk of metastasis. So it grows radially at first. And so if you see an irregularly shaped dark pigmented lesion with atypical melanocyte proliferation, you should think of a melanoma. All right, so we have a 15-year-old girl who presents to the dermatologist with a dark spot in her lower abdomen that she's noticed for the past 2 months. She has denied pain, itching, and changes of color. She has no significant medical history, and she's going through puberty, and she has a 4 millimeter round hyperpigmented lesion located 2 centimeters lateral to the umbilicus. It has a darker center, smooth borders, and appears slightly raised. Surrounding skin is otherwise unremarkable. What is the diagnosis? Okay. Pubertal girl, small pigment along the milk line. Going to be accessory nipple. Lentigo is a flat sun-related lesion. And these dermatofibromas are going to be firm and fibrous nodules, often the dimpling signs. And the epidermoid cysts present with a mobile dome-shaped nodule with a central punctum, and they're typically not pigmented. And our next question, a 65-year-old man has a history of cough, COPD, and chest discomfort. He has large, bloody pericardial effusion with high protein and low glucose. Which malignancy caused it? All right, so lung cancer is the most common source of malignant pericardial effusion. Breast cancer and lymphoma are also common in women and younger patients, and prostate cancer is from bone mets, not pericardial. And the pancreatic cancer has the peritoneal spread, not pericardial, and the esophageal cancer has direct invasion or fistula, but it's rare in the case of effusion. And laryngeal cancer is associated with a local tumor, no pericardial involvement. And so our answer is going to be the lung, because it's a leading cause of malignant pericardial effusion. Other ones are just less common. You got to know those associations. And basically, there's a tumor invasion or lymphatic spread to the pericardium, and there's exudative effusion that forms that increases the protein and decreases the glucose, and there's bloody fluid due to the tumor vascular invasion, and the pericardial space fills up, and you get tamponade and decreases the preload, and hypotension is going to be caused. All right, so it'll usually be like an older man with COPD, and that suggests there's like a smoking history, maybe some lung cancer risk. You'll see distant heart sounds at the pericardial fluid that dampens the heart sounds. JVD and hypotension would be the tamponades triad, the Beck's triad, and you have the enlarged cardiac silhouette, and that's just pericardial effusion. And the bloody exudated pericardial fluid would be a malignancy until it's proven otherwise. All right, so the other answers: prostate metastasizes the bone, pancreas spreads to the liver, esophagus may invade the mediastinum, larynx spreads locally to airway structures of the heart. So 40% of lung cancer patients actually have pericardial metastasis on the autopsy, and that's just how often this will just sneak into the sac around the heart. Loves to do that. And so neoplastic pericardial effusion in older adults is most commonly due to lung cancer. All right, next we have a 6-month-old girl is brought to a pediatrician with persistent diarrhea and failure to thrive. Her parents report that she had several episodes of respiratory infections over the past months, including 2 incidents of otitis media and recent hospital administration for bronchiolitis. On physical examination, she appears pale and lethargic, and lab studies reveal anemia with the hemoglobin level of 7.2, and flow cytometry shows absent expression of human leukocyte antigen DR. Further analysis reveals marked deficiency in which of the following cell types. All right, so this is Bare lymphocyte syndrome. This is type 2. It's a form of SCID due to an MHC2 deficiency. All right, and so we have to know MHC1 interacts with CD8 positive T cells. MHC2 interacts with CD4 positive T cells. And if MHC2 is missing, then CD4 T cells can't positively be selected for in the thymus, and you have profound CD4 deficiency. And that impairs the B cell help and the antibody production, so you get combined humoral cellular immunodeficiency. All right, so if you have an absent HLA-DR on flow cytometry, then think of an MHC2 deficiency. And if you have recurrent respiratory and GI infections of infancy, then it's going to be a severe immunodeficiency, and the failure to thrive and chronic diarrhea is a hallmark of SCID. So we have some genetic defects. Autosomal recessive defect of the transcription factors that regulates these MHC2 expressions. And so the answer is CD3 positive T lymphocytes. And this is including both your CD4 positive and your CD8 positive T cells. Because in flow cytometry, CD3 is the universal marker for all mature T cells. And so CD4 is a subset marker, but it's not listed as one of our options. Otherwise, we would have chosen that. CD4 is that subset marker. And if CD4 positive T lymphocytes was an option, then that would be the more precise answer. But basically, CD3 is basically saying, hey, this is a T cell. And an MHC2 defect, you'd have no CD4 positive T cells. And so a loss of a whole subset of CD3 would be the case. Kind of weird, but yeah. So you think of SCID with a deficiency in the CD3 positive lineage. All right, so here we got a 35-year-old man, history of type 2 diabetes, struggle with weight management, basically obesity, poor adherence to lifestyle changes, and HbA1c of 8.5. So which strategy would improve his adherence to the recommended lifestyle change? And our answer is going to be to schedule monthly check-ins and monitor progress and adjust skills as needed. Got to do those ongoing structured follow-ups, very important. The journaling, family member, educational stuff, cool beans, but it's the reinforcement is what gets the adherence higher. The 1-year follow-up is way too infrequent. Journaling is just self-awareness, but it's not going to provide accountability. You have to literally do the follow-ups. Family fitness class can help, but structured follow-up is going to be more impactful. All right, monthly check-ins for type 2 diabetes. Okay, so hypertensive patients are randomized to drug A or drug B, and the outcomes are measured. And then after a washout, the groups swap treatments. What type of study design is this? This is a classic crossover study. So participants receive both treatments in the sequence, and they act as their own control. RCTs compare groups in parallel, not switching treatments. Cross-sectional is single point snapshot. Cohort is observational. Case series is just descriptive. Bottom line, crossover design allows each participant to receive both treatments sequentially. All right, we have a 45-year-old man, palpitations, sweating, shortness of breath that has occurred intermittently in the past couple of months. He's been feeling intense fear and discomfort, and he's got that feeling of impending doom. On exam, his vital signs are within normal limits, and there's no significant abnormalities noted. After a thorough evaluation, he's diagnosed with a panic disorder. Medication is prescribed that enhances the effects of neurotransmitter gamma-aminobutyric acid, GABA. By binding to the specific sites of the receptor, which of the following medications is most likely prescribed in this patient? All right, Lorazepam. That's a benzodiazepine that enhances GABA-A by increasing the chloride channel opening frequency. Barbiturates would increase the duration. This is a frequency. So it would provide rapid relief in acute panic symptoms. And sertraline is going to be the long-term use, and propranolol is for performance anxiety, and trazodone is for depression, insomnia, and phenobarbital is a barbiturate. So you don't use that in panic disorders. All right, so here's the explanation. First-line panic disorder would be a benzodiazepine like lorazepam, enhancing the GABA's receptor effects. Now we have a 14-month-old Hispanic boy brought to the clinic by his mother due to concern about unusual leg shape and frequent crying. He was born full term and has been primarily consuming a homemade diet of pureed foods and cow's milk without any supplements. On examination, the child exhibits genu varum and swelling of the wrists and the knees. Additionally, palpation of the ribs reveals a rheumatic rosary. Lab tests reveal normal calcium levels and low serum phosphate levels. Which of the following lab findings would be most likely observed in this patient? All right, so we got some rickets going on, and this is resulting from the defective mineralization of the bone due to vitamin D deficiency. So vitamin D, calciferol, to that 25 hydroxyvitamin D in the liver, then leads to that 125 dihydroxy vitamin D in the kidney. And vitamin D is required for calcium and phosphate absorption in the gut, and so deficiency leads to less phosphate and sometimes normal calcium, but that's thanks to the parathyroid hormone mobilization and secondary hyperparathyroidism. And so we have a Hispanic boy, 14 months, homemade diet, cow's milk. So there's a risk for vitamin D deficiency, the low sun, and the poor supplementation. And we see all this other stuff that leads us to think of rickets. And so in labs, you have low phosphate, maybe some normal calcium, and secondary hyperparathyroidism. So the risk groups are going to be those exclusively breastfed infants in the dark skin, limited sun exposure. And the complications are bone deformities, hypocalcemic seizures. And this is kind of similar to osteomalacia in adults, the defective mineralization of the osteoid. And so the pathophysiology here is you have less vitamin D intake, which leads to less 25-hydroxyvitamin D storage form. And you get decreased intestinal absorption of calcium and phosphate. And the lower calcium triggers increased PTH, and that mobilizes bone calcium, increases the phosphate wasting. And the net effect is low phosphate and normal to low calcium and high parathyroid hormone. And so our answer is indeed going to be B. All right, so here's the explanation. Here's kind of the mechanism we more or less outlined. So low serum phosphate and a nice little kiddo here is nutritional rickets. You can see what it looks like over here on this side of the screen where my face is pointing. And you can expect an increased parathyroid hormone and decreased vitamin D. All right, our next question, we have a 45-year-old woman presenting to her primary care physician for a routine annual checkup. She is concerned about her bone health, as her older sister, who is 52 years old, was recently diagnosed with osteoporosis. The patient has no significant medical history and reports leading an active lifestyle, which includes jogging and yoga. She smokes occasionally at most social gatherings and drinks 2 glasses of wine weekly, BMI 22, takes no prescription medications, and relies on meals prepared at home. The patient asks what she can do to assess her risk of developing osteoporosis, which the following additional information would be helpful in evaluating her risk. Well, definitely calcium and vitamin D intake, right? Your dietary history. So the 2 most important factors, risk factors that is, for osteoporosis and calcium intake, or the 2 most important modifiable risk factors for osteoporosis are calcium intake and vitamin D status. Now, lifestyle matters, but without the adequate bone-building nutrition, the prevention is going to fail. All right, so here we just have to understand that osteoporosis is due to low bone mass and microarchitectural deterioration, and it's a fragility failure. So you have the peak bone mass in your late 20s, and there's a rate of bone loss after menopause, and that determines your lifetime risk. And the risk factors are going to be low calcium, vitamin D intake, smoking, alcohol excess, and low BMI, and a sedentary lifestyle and estrogen deficiency. And she exercises, she has a normal BMI, she drinks moderately, and so really the key missing piece is just her calcium and her vitamin D. All right, there's our brief explanation. And what's crazy is that most women actually don't reach their recommended calcium intake, and that is one of the biggest preventable causes of osteoporosis. So you got to watch out for that diet. Calcium and vitamin D are crucial for assessing osteoporosis risk in women, especially if they have a family history. Thank you guys so much for watching. Please like and subscribe if you found this helpful, and we'll see you guys in the next video.